Okay, welcome all. I'm Paolo Cassano. These are the MGH brain-PBM clinic rounds, and today is March 31st, 23. It is my great pleasure to introduce Dr. Fernanda Rossi Paolillo from the University of the State of Minas Gerais, and Dr. Nivaldo Parizotto from the University of Brazil. They're going to discuss today about their paper on the use of combination of electrical stimulation and PBM for stroke patients. Please, Nivaldo and Fernanda, take it away.
At first time, I would thanks to invitation. Thank you so much to be here. To this a lot of people and the very, very important people here. I will share my presentation right now. Okay. Did you see?
Yes, we can see.
Yes.
All right. Excuse me, I'm not so good in English because a lot of time I am in Brazil and I lost a lot of English because I speak only Portuguese here. For this reason, maybe sometimes I need help from David. It's here to me, right? Thank you so much for your understanding. Okay, this work was done using transcranial laser photobiomodulation associated with neuromuscular electrical stimulation. It's like a regular treatment of neuromuscular electrical stimulation in post-stroke dysfunction. The difference in the control group and the treatment group is exactly photobiomodulation. Both groups receive electrical stimulation. Okay, is this our publication in December 22? Okay. Everybody knows about the combination of light with the tissues, the chromophores, using the energy to transform this electromagnetic energy in biological energy, like ATP. The principal chromophore is cytochrome C oxidase, but we know nowadays that we have one way to have effects by mitochondrial effects and non-mitochondrial effects. Both effects can be active in the photobiomodulation therapy. Via chromophores, we have this action like acceleration of electron chain transport and increase ATP synthesis, antioxidant activity and generates changes in gene expression, anti-inflammatory and analgesic action. We know about the increase of microcirculation, and we have a lot of papers showing increase the regeneration, improvement regeneration and repair in different kinds of tissues. This is what we trying to do: introduce light to the brain using photobiomodulation device, and we know the hypothesis that the photobiomodulation, transcranial photobiomodulation, can increase angiogenesis, has an anti-apoptotic effects, anti-inflammatory, antioxidant, increase cerebral blood flow, and it has a consequence of great oxygenation in the brain and change in motor neuron excitability and neurogenesis and synaptogenesis increasing. It's Dr. Hamlin figure, and okay. This is some kinds of devices used in different approach for transcranial photobiomodulations. But we have developed one prototype, our prototype, to do that. For neuromuscular electrical stimulation is like it's a common treatment that we have a lot of papers showing the improvement of movement, and especially for this kind of electrical stimulation for fibular nerve, for example, and for increase the movement of the hands. In 1960, Liberson in Long and Macchiarelli used this kind of electrical stimulation to treat stroke patients. It's like something like that. The neuromuscular stimulation try to restore functional abilities in post-stroke patients, improve sensor and motor function, reduce spasticity and pain, increase range of motion, and enhance fatigue resistance and muscle strength. We have in clinical practice used this kind of stimulation a lot. It's not so difficult to do that. And in many cases, we have very interesting results, accelerating the gait of the patients and increasing the movement in stroke, especially because we have a lot of patients with stroke increasing, including in Brazil. Maybe around the world, maybe 6 million of people died due the stroke disease or post-stroke sequelae. And in the stroke, we have a lot of problems like cognitive problems, like thinking, reasoning, judgment, and memory. We have impairment in sensory motor function. Maybe some patients have problem to eating and swallowing and communication. Maybe in vision and perception of orientation to the surroundings. Maybe some patients have emotional and social problems because they have decreased in mobility, and because everything we could see, these patients reduce a lot of the quality of life. Our study was approved in the Ethics Committee of Federal University of San Carlos, and we attribute in two groups. One, using electrical stimulation associated with transcranial active, and another group, transcranial electrical stimulation associated with transcranial PBM, but placebo. It's only simulation of the treatment. We have here inclusion and exclusion criteria. We use it because the number of patients that we tried was a lot, but only a few patients was included in the study, because some of them was excluded or not attributed to the inclusion criteria. The volunteers was referred from the medical clinics using hemiplasia diagnosis from stroke. This is the groups we have here. We can see the similarity between groups here, and we have a lot of we did a lot of tests to understand exactly what these patients has when they arrive the service, our service. And here is the table with the parameters which we use it, like three wavelengths, 660, 66, 60, 80, 80, and 90, 80 nanometers, three wavelengths. It is constructed like a cluster. You can see here with infrared image here. The average power per laser was 60 milliwatts, and average power per cluster 20 milliwatts, and 12 sections was done in these patients with a radiance per treatment. It's a lot of energy, and total energy per treatment, it's a lot. We can see here, and this is the electrical stimulation device that we use it. We use it 50 hertz of frequency and 250 microseconds post duration, and 20 seconds hold the muscle contraction, and 10 seconds relaxation for the muscle. Here is some photos from the treatment. The placebo and active treatment was done after 5 minutes. With we start with electrical stimulation during 30 minutes. The duration of PBM was 15 minutes, 1 minute per site in the head, in the skull. For this reason, we start the PBM treatment after 5 minutes after the electrical stimulation, and we put the PBM during the electrical stimulation treatment, and we finally complete after 30 minutes the electrical stimulation, and and the treatment was completed all the treatment. This is a thermal image that we did after the treatment of the photobiomodulation the skull. It was actually to understand the temperature that device could change in the skull of this patient. And in the site of the electrical stimulation as well, you can see here. We wait a little bit, 10 minutes for thermalization.
Nivaldo, I'm going just to ask a quick question. So I might have missed this. So was the site of irradiation tailored? Was it decided based on the lesion?
Yes, it was irradiating all the skull, both of sides, 15 sites is the size of the head of PBM device, was put in different parts of the skull, and complete all the brain, all the skull of the patient, right?
Thank you.
For this reason was 15 minutes, 1 minute per site, right?
Got it. Thank you.
Okay, we have here some results. It's interesting here. We could see here the influence of hair or not during irradiation. The temperature with hair increase more than without hair. The people that doesn't have hair in the skull, we could separate the analysis of both these subgroups actually, and we can see here in the center of the device we can see the change in the temperature, but in the border, if we can see here without hair, the temperature is not changed in the border of the area in the focus of PBM application. And here we in the side of neuromuscular electrical stimulation, we measure the temperatures as well. We can see here the temperature during and after. We can see the muscle increase the circulation as expected, right? Okay. To the intention to be fast here, our presentation, we can see the increase in the temperature with hair, but both in this 3-wavelength device, we can see the increase in the temperature, a little bit in the skull. And here our results. We can see here is like a sensor to movement. We use it to measure the number of movements that the people make during pre-treatment and post-treatment. And we can see here the number of blocks. You can see next slide the test we did. And we can see here the change in this number, the number of blocks that the patient could change the place. It is okay in the treated group, but it's not the same in the placebo group. The single section of transcranial laser in this condition, like factory in collaborators, has results very interesting in health patients, and they could see the transcranial laser potentiate the exercise induced by electrical muscular stimulation in limb extension, in upper limb extension, and hand extension, result in manual dexterity, due the systemic effect of photobiomodulation in this way. The spasticity was measured by X-ray Ashworth scale, and we can see here the same results is not so different between placebo and treat group in the spasticity. And okay, but in pain we could see difference. The pain score in treated group was more is larger than placebo group. The difference, the delta of the difference in between pre or post treatment was different between groups. Here are some discussions, and the qualitative assessment is here. Some questionnaires was applied for these subjects, and we can see difference in the physical factors and social relationships, different in treated groups, but not in the placebo groups. And the total score was different. And the scale of well-being was different in the treated group and was not different in placebo group. It's very interesting results, I think. And the mini-mental state examination as well, we can see different here in attention and calculation, and maybe the microcirculation in the brain, and the total score was different as well. And okay, we have some discussion here because Dr. Nazer is here, have some works about this subject, very interesting works. And I will show the video of these patients. Here, the good hand is not affected hand, okay, and here the affected hand, okay, okay. The test is exactly this. We can measure about the number of movements using this device. And the velocity, the speed of movement, everything is a accelerometer. After that, we did, we did ex vivo study, compared the bone transmission and cadaver transmission of infrared and red irradiation. We can see here exactly this device, the same device that we use. Sorry, it's in different, it's another patient test. We can see here is the tug test with using electrical stimulation or every time, but when the patient could include in the group of placebo or PBM. Here we can see two videos of the patient. This patient could improve the speech function, was not subject of our measurement, but the patient report that. This patient talking about exactly that. He has had difficult to speak, and after the treatment could improve the speech. Here, the functional beside the gait was not improved, but functional test in dorsiflexion tests was done well, right? Okay, the ex vivo is here, as you can see, to consider that the light could penetrate to the brain, and we could see the red was not high penetration, but infrared was well. And I think it's better to discuss something because it's easy to explain some different kinds that we could see in the work, right? Excuse my English, poor English.
Thank you so much. Thank you so much, Nivaldo. No, it was a very clear presentation, and thank you, Fernanda, as well, for agreeing to have your paper discussed. So I see there is a question from Leone, and we'll say that David can interpret in case we have a question for Fernanda as well.
course.
Go ahead, Leo.
Thank you for the presentation. That was very interesting. I think I missed it, but what was your sham intervention? What was the sham or placebo laser or
Placebo
LED?
or sham. It's the same device without turn on. It's turn off the device.
It's turned off.
Exactly.
Okay.
Right.
Okay.
But it's the same device.
Okay.
You're talking about the laser. I mean, never mind. I'm going to hear what the answer is. Thank you.
Okay, you can.
Are you finished? I have a question.
All right.
Sham. The laser is the sham part, right? Only the laser is the sham. Did they also get neuromuscular stimulation real on the sham, or just everything was?
Both groups has electrical stimulation.
That's what I thought. And then the electrical stimulation, with tens or microamps tens, you can increase the intensity. So I'm going to assume that was milliamps tens, and the patient could feel it. Is that correct? And the patient determined when it was too much?
Yes, exactly. The patient need to feel the contraction. We can see the contraction using electrical stimulation, right? We can see exactly the contraction. We can increase until the patient that talk. Okay, it's good contraction. It's good to me.
Okay, thank you. So that's milliamps tens, and they could clearly feel it. Okay. Now, my other question, and thank you for your talk. It was really good and very interesting, and I appreciate it. I'm confused. I need more. I just wanted to get more information. When you say all over the head, I want to know, did you include the midline?
Yeah.
You did include the midline.
Yes.
How many placements on this midline?
Fernanda, você lembra na região mediana quantas aplicações? Foram 15 aplicações em todas as regiões, incluindo? Sorry.
Você tá muda, na verdade.
Tá muda, Fernando. Actually, Dr. Nazer, is what's applied in every part of the brain, including midline. 15 place, 1 minute per place, per site, right? Including the anterior prefrontal brain, lateral cortex, posterior cortex, every part of the brain was irradiated.
Well, if there's 15 and you would have then perhaps 5 on the, I mean, you could get 5 on the left. Would you get 5 on the left, 5 on the right, and then 5 down the middle? Is that what it is?
Yeah.
It's very important in language. All I want to say is that is very important in language to only treat the left side. So that would be the dominant side for language. And we never treat the top vertex, because when you treat the top vertex with your LED cluster head or laser, you're going to get the left supplementary motor area and the right supplementary motor area. And we found that interfered with speech. So I guess we have different results, and that's fine. I would like more information on the improvements on the speech output and language That would be helpful. I don't know how many aphasia patients you had.
I understand your question because I did application in another paper that another work in patient with head pain. We put the photobiomodulation only in the sensorial primary area, and 3 points in the primary sensorial area, and it's our main objective to irradiate, right? And in this case, we did a different approach.
Oh, okay. Oh, and I think that what you did, I'll be very quick here. I think that, yes, you delivered, 5 spots left, 5 spots right, 5 spots down the middle. Then you followed that up with electrical stimulation on where the paralysis was. And in your stroke patients with language problems, it's going to be a right hemiplegia. And I think what you did then was actually get the network going back to the left hemisphere only, and that's for language. I think it was because you followed up with electrical stimulation only on the paralyzed side. If you had done both sides, paralyzed, not paralyzed, it would be a real mess, and you'd do that. But I think that where we differ is I think you rescued the photons to be effective in the left side of the head by putting electrical stimulation the patient can feel on the paralyzed side. So I think that's why it's different. Thank you, though. That's very.
Thank you. Thank you for your.
I do have a question. Did you send the patient home with any home treatment devices?
Yes, it's a good idea because I think that it's planned to do something like that in the future, maybe.
Oh, okay.
But this work was did in the clinical set.
Good. Fine. Excellent. Thank you.
I had a question about timing of the effect. You showed effects that are related to pain, effects are related to psychological domains like positive and negative affect, and then motor effect. Was there any difference of how quick you could see these changes?
Você entendeu, Fernanda? Qual a brevidade, qual o tempo para observar efeitos, tanto motores quanto de outros aspectos?
Nós não fizemos avaliação nesse intervalo aí que deu mais ou menos 3 meses, né? Mas eu acho que no meio dessas sessões, no meio desse período, os pacientes já estavam relatando essas melhoras, embora não foram avaliados.
Fernanda talked about our study has a 3-month duration, 12 sessions, right? And during in the middle of the treatment, we could see some improvements in different aspects of the patients, but we did only the analysis in the final, when they start and the final of the treatment, right? For this reason, we can talk about only in these results as well.
So there were no intermediate assessments.
Yes.
Got it. Got it.
Unfortunately,
your impression is that there wasn't any particular timing that, I don't know, did pain improve before and motor symptoms improve later, or were depressive symptoms or affective symptoms improving only after the motor function recovered, or they were improved independently from that?
Você se lembra, Fernanda, se os aspectos afetivos começaram a melhorar junto com a melhora motora ou só depois? Ou antes ou depois?
Eu acho que por ser novidade o tratamento, isso já foi motivador, né? Isso desde o começo. Eles se sentiam pessoas diferenciadas no programa. Então, isso já era bem nítido.
E diferença entre os grupos nesses momentos, não?
Nesses momentos eu não percebi.
Fernanda talked about the patients feel incorporate with the feeling to the treatment during the application of devices, both electrical stimulation and laser, right? For this aspects, the patient feel good. They feel more incentivized to make some movements or something like that. But she doesn't note a difference between the groups, placebo or active treatment.
Thank you. I see another question from Leon.
Yeah, can you expand a little bit more about the ex vivo model and the lack of penetration?
Yeah.
Did you use the same parameters of irradiation? Did you manipulate those parameters to see if there was penetration, or why you think there wasn't any penetration?
It was the same parameters. Actually, we did these tests to test the quality of the device to put the light in the brain, into the brain, right? It's our, but we know that ex vivo model is not so good because it's a cadaver and the bone isolated. It's not so good. We know that we have a circulation, we have a lot of different aspects in the tissues that can absorb different wavelengths, different conditions to absorb light in the tissues, right?
This was the specimen fixed?
Yes, in the formally, it's a problem.
Thank you.
All right. Any follow-ups, or there's actually a question from Fred. Go ahead, Fred.
Yeah. Hi. Let me. I'm just wondering if there were in a lot of my patients, there's an immediate effect at the treatment, so they feel better after a 4-minute treatment. Did you observe that?
Yeah, the problem that our objective in this work was not to see the acute effect, but the after 12 treatment effects, 3 months after effects.
Right, but did you notice any as you were doing it? Did patients say, "Oh, that felt good"?
Perfect. It's that I speak about Fernanda talking about the patients feel included in after they included in the treatment, they feel better only for this reason, included in the treatment to see the movement in the electrical stimulation and the laser acting in the brain, or maybe feeling that the laser is turned on or turned off. They doesn't know exactly which group they are, but yes, they feel better only after the treatment. Okay, it's exactly.
I think one fundamental difference, at least to my understanding, between how you treat it and how Fred is treating his patient is that Fred uses high power laser devices that are around 250 milliwatt per square centimeter with a kind of, and correct me if I'm wrong, Fred, with a sort of a pinpoint, not pinpoint, but about 1 square centimeter kind of area.
Mhm.
Well, your, for what I've seen, your average fluence was around 20 joule per square centimeter. And then, so you had very extensive surfaces, which I assume it seems like you were delivering 7 kilojoule per session. And I assume that
I actually no. What I did was just one site.
oh yes.
I did
Yeah.
either a F3 or F4.
Yeah, no, I'm
Before-
sorry, Fred. I understand. I guess I wasn't clear. I shifted from you to Nivaldo.
Oh, okay.
So I'll say Fred did. No, it was my mistake. Fred is doing roughly 1 square centimeter per one side, unilateral, choosing based on valence, the side to treat, and high power, 250 milliwatt per square centimeter. And Nivaldo and Fernanda have been doing very extensive surfaces with, my understanding, low irradiance, because your total amount of energy is only 7 kilojoule, which is pretty good, of course. But of course, on such a large surface, means that you're using, for such extended time, you're using relatively low irradiance. Correct me if that's, yeah. And so, you might not see the same response in the patient, and not surprisingly, you might not see much penetration with kind of low irradiance.
Yeah, I agree with you. I think that the number of the photons penetrate deeply is better in the Dr. Schiffer using device. I think that our approach distributes more equally around the brain photons, but maybe doesn't penetrate deeply like the device Dr. Schiffer used, right? I think that you has reason about that.
Any other comments or thoughts? I see Marnie is raising her hand.
Oh, thank you. I had a question. You are only treating once a week. Now, I'm curious how you chose that time to treat, because usually in these studies, we would treat twice a week, 48 hours in between at least, or 3 times a week. And I was just wondering how you chose that. And I got lost. Are these only chronic cases, or do you have acute and chronic? I'm not sure your range of months post-stroke when you took them into your study. But let's start out with the number of times a week, how you chose once.
Yeah, I think that it was the routine of the clinics that we use here for these patients. It is many of these patients has difficult to go to the clinic. They are poor patients. They doesn't have money to take transportation to the clinic. You can imagine something like that.
Sure.
For this reason, one time to week is was the choosing for this reason.
And they were chronic then? I mean, I got lost on when they started in
yes, chronic.
How many months post? Like 6 months to 6 years?
Actually, we have a mix. Some of these patients has not so long time lesion, but and some of them was more little time after lesion, but and they have different severity of lesions.
I know. It's really complicated.
It's a problem, you know.
Yeah, I know. I know well. And then if it's cortical, or is it only subcortical white matter?
Yeah. It's problem to standardize the patients. It's difficult.
But you had a whole range, and you could take acute cases 2 weeks post-stroke if you wanted. Oh, good. Or 12 years post-stroke if you wanted something. What I'll have to go back and look at the slide.
It's a
but
good
thank
idea.
you.
Perfect.
It was practical decision.
Yeah.
Good. Thank you.
And we are in the last minute. Any last minute comment, as the saying goes? All right. Thank you so much, Fernanda and Nivaldo, for being here. This is a very interesting topic about combining electrostimulation and PBM in this special population, and very inspiring. Thank you all for being here, and to be continued.
Thank you so much for invitation. Good to see you, Dr. Chen. Everybody, thank you so much.
Thank you. Nice to meet you.
Thank you.